Posterior to anterior pressures, also known as PA pressures, are extremely commonly performed in both assessment and treatment, and especially in the thoracic spine. They can be used for trying to detect hypomobility, although the literature doesn't suggest that we're very good at it. I'm going to suggest that if you can use the lightest possible amount of pressure, you will be more accurate at picking up areas of hypomobility. So as you perform your PA pressure, whether it's over the spinous process, the transverse process, or the rib, push as lightly as you possibly can and try to detect the least amount of pressure required to induce movement. And compare that to the opposite side. If it requires more pressure to induce that movement, then that's a stiffer side. And if it requires less, then it's less stiff than the opposite side. You can use your thumbs or you can use your pisiform. Just always remember to use as little pressure as possible if you're trying to detect mobility. If instead you are trying to provoke pain, which the literature suggests we are much better at, then you're going to use more pressure and it's going to be faster, and you're going to try to notice if there's any muscle spasm. So now let's go to our model and demonstrate this. So over a segment in the thoracic spine, I can put my pisiform on the spinous process and very gently push down until I perceive a little bit of movement and compare to a segment above or below. There should be a little movement without much pressure. If I want to do this as a pain provocation, I am going to go faster with a little more pressure. I do have to dissipate my forces around that spinous process, because if I dig my bony pisiform into the bony spinous process, of course it's going to give me a false positive because it's not comfortable. When I come out to the facet joints, I won't actually be on the facet joint, I'll be on the transverse process. I'm not going to stabilize. I'm just going to gently press down with as little pressure as possible, slowly perceiving how much pressure, how many ounces of pressure I need to place to induce movement, and then I'm going to come out to the opposite side and do the same postero-anterior pressure and see if it feels similarly. If I push really hard, both of them move, but I don't perceive if there's a difference. You can also change the direction. Instead of going straight postero-anteriorly, you can go on that same transverse process and try to induce a superior movement of the transverse process and compare to the opposite side, and that relates to a superior glide at the neighboring facet joint. Or I can do the same thing on the transverse process and slowly and lightly try to induce an inferior glide and compare to the opposite side. If I push that same light amount and it doesn't move, then it's stiffer. And if I have to apply a bit more pressure to create the movement, I recognize that this is stiffer than the opposite side. Until I do my stability tests, I can't tell if this is moving too much or if the stiffer side was moving too little. It's just a comparison that they're not equal, and they should be. If we do exactly the same thing, but come out more onto the rib, just past the transverse process, we can do a straight PA, we can do an inferiorly directed glide, or we can perform a superior movement of that rib. Again, what's the lightest amount of pressure to start the movement, as opposed to pain provocation tests where you go in and you use a quick impulse to see if that causes pain or reactive muscle spasm. And that's PAs in the thoracic spine.